Yeah, hello guys. Welcome you all for this second year live class for pharmacology. In this, we are going to discuss some MCQs of antimicrobial agent. Very important topic, antimicrobial agent. For complete videos, you can refer the second year course in which we have discussed all the details of antimicrobial agent. We will discuss some MCQs, and all these MCQs you can see these videos and you can cover all these MCQs. So let's start with the first MCQ. So the first MCQ is all are effective against anaerobic microorganism except all are effective against anaerobic microorganism except which is not effective for anaerobic purpose, anaerobic infection. In antibiotic, one of the frequently asked thing is which is effective, which is not effective. So we should know the selection of antimicrobial agent. So which is effective for anaerobic infection? Remember a simple trick. This diaphragm, above the diaphragm, the better drug is clindamycin or some cephalosporin. Below the diaphragm, the better drug is metronidazole for anaerobic infection. Remember metro for below and clinda for above. So in the chest infection, anaerobic pneumonia, we use the clindamycin. We can use the cefoxitin, but below this diaphragm we use the metronidazole. So we use this, and we use this for anaerobic infection. But gentamicin is one of the aminoglycoside. It is one of the aminoglycosides, and aminoglycosides need oxygen because they are highly ionized drug. They need oxygen for their entry into the cells. That's why without oxygen there is no effect of gentamicin. So that's why gentamicin is the correct answer. Gentamicin is the correct answer. So all are effective against anaerobic infection except, so we use the metrogyl, we use the clinda, we use the cefoxitin, but not the gentamicin. So what is the correct answer? The correct answer is gentamicin. Now let's see the next question. So don't forget that gentamicin or aminoglycosides are not effective for anaerobic infection. Next, again a very important topic, atypical pneumonia. So atypical pneumonia, you know what is the most common cause of atypical pneumonia? The common cause of atypical pneumonia is mycoplasma. The other, we have the chlamydia, legionella. So Legionnaire's pneumonia, chlamydia pneumonia, mycoplasma, all these are causing atypical, but mycoplasma is most common. That can be treated by all of the following drugs except. So again we need to find the correct answer. The options are cephalosporins, fluoroquinolones, tetracycline. Okay, so Gaurav has given the correct answer. So guys, in the atypical pneumonia, mycoplasma, chlamydia, there is no cell wall. So definitely the cell wall synthesis inhibitors are of no use, because if there is no cell wall, it is of no use. So remember, cephalosporins, penicillins, these are beta lactams, and beta lactams are not having any role in these type of organism. What is the drug of choice? The drug of choice is macrolides. Azithromycin is the drug of choice. But we can use the doxycycline if needed. We can use the fluoroquinolones like levofloxacin, but there is no role of beta lactams because these are cell wall synthesis inhibitor. So what is the correct answer? Cephalosporin. So in atypical pneumonia, the best is macrolides, but the drugs which are not effective are the beta lactam. So I told you in these two MCQs, these are what is the effective drug, most effective drug, and which are not effective drug. You should know these type of questions are important. So we have covered all these things in our second year videos. Next is the third one, antimicrobial drug best to treat gonococcal urethritis, gonorrhea, gonococcal urethritis. You know guys, gonorrhea, one of the common urethral infection, sexually transmitted infection in India. STIs are very common, and we should know the management of STI. Then gonococcal urethritis, gonorrhea. In gonococcal urethritis, nowadays the best drug is ceftriaxone. The best drug is ceftriaxone. Single dose ceftriaxone. Very good, guys. Very good. So single dose ceftriaxone is best. We use the injectable, but this is injection. Huh? So this is injectable drug. Single dose. That is best. We use single dose ceftriaxone, but what are the alternatives? The alternative drug is doxycycline. Doxycycline is oral drug. So which is the oral alternative? That is doxy. Penicillin is nowadays resistant because nowadays you see the gonorrhea is PPNG. Penicillinase producing Neisseria gonorrhoeae. So penicillins are resistant. Already resistant, we don't prefer, we don't use. Ciprofloxacin may be used, but resistance already seen with the ciprofloxacin also. So we don't prefer. So the main drug for gonorrhea we use is the ceftriaxone, or we can use the doxycycline, or we can use the spectinomycin. Spectinomycin. These are the drugs we use for the gonorrhea. Even non-gonococcal urethritis. Non-gonococcal urethritis, if we talk about the non-gonococcal like chlamydia, then azithromycin is the preferred drug. And doxy is the drug which can be used for non-gonococcal also, but ceftriaxone is not for non-gonococcal. That's why nowadays you will see doxycycline is one of the commonly used drug for sexually transmitted infection because it covers the gonococcal as well as non-gonococcal both. Again remember in the urethritis also, this diaphragm, above the diaphragm azithro, down the diaphragm doxy. Above the diaphragm azithro, down the diaphragm doxy. Very effective drug. Next question. First you need to identify which generation drug is this. Cefepime. All are true except. So we should know about the new generation, cephalosporin. So cefepime, all are true except. Which generation drug is this? Cefepime. Remember the pi. I told you in the videos pi means 4th generation and roll is 5th generation. So this is cefepime. So in cefepime, all are true except. First, effective against Pseudomonas. So yes, 4th generation is effective against Pseudomonas. 4th generation is effective against Pseudomonas. They are effective against gram-negative infection. Some of the 3rd generation effective. 4th generation is effective against Pseudomonas. They are not the first choice because these are the reserve antibiotic. Use via parenteral route twice daily. So yes, these are only parenteral. They are only parenteral. They are not oral. So 4th generation only parenteral drugs we have. So that is also true. Then it's a 4th generation. Yes, obviously. Narrow spectrum, no. It is covering the gram negative mainly, but also cover the gram positive. So it is covering both. That's why it is not narrow spectrum. It is broader spectrum, reserved. It is the reserved antibiotic for the serious infection where you cannot use the 3rd generation. 4th generation can be used. So the correct answer will be option D. It is not the narrow spectrum. So the correct answer will be this one. Let's see the next question. So as usual in this video you will see we'll start with a very basic thing and then the standard will increase with every MCQ. So start with basics. Every question is important. First basic thing, then some dose related thing, then some more specific thing, and then clinical things. And you will see the same thing in every video of pharmacology 2nd year. So let's see this. True regarding, and this should be the approach. We should know all the things. First conceptual, basic, then important drugs, and then clinical part. This should be the way of study in 2nd year. True regarding the treatment of late latent syphilis. Now you can see, we know what are the drugs for gonorrhea, syphilis. Now we need to know what is the dose, how we are using. So in the late latent syphilis, what is the best treatment? Now if you see the option, benzathine penicillin is used, A, B, C, D, all there is same drug. So it's confirmed that we use the benzathine penicillin. Remember, benzathine penicillin is the penicillin which is used for all syphilis patient except neurosyphilis. Except neurosyphilis, we use the benzathine penicillin for all. So we use the benzathine penicillin, first thing, except neurosyphilis. In neurosyphilis, we use the crystalline penicillin because it is not reaching to brain. Now, what about the dose? And what about the, single dose or weekly dose or every 4 week? What? So, every 4 week, no. That is for prophylaxis of rheumatic fever. That is for prophylaxis of rheumatic fever. Benzathine penicillin single dose. Is this true? In the primary syphilis, early latent syphilis, we use the single dose, and that is not 1.2, that is 2.4. So this is not correct. 2.4 million unit single dose we use for primary syphilis, not 1.2. Every 4 week, no. So what is the correct answer? It is 2.4 million unit every week for 3 weeks. So total 3 dose. We use the total 3 dose. 2.4, 2.4, 2.4 weekly dose. Total 7.2 in 3 weeks. That is the best treatment for late latent syphilis and secondary syphilis. That is the best treatment. Also for cardiovascular syphilis. Cardiovascular. But remember, in neurosyphilis it is not effective. In neurosyphilis we use the crystalline benzyl penicillin. Every 4 hourly we give the this crystalline benzyl penicillin G, not the benzathine. Let's see the next question. So this is the correct answer. Now the next question. Simple recall based question. Ivermectin is used for. So ivermectin is one of the anti-helminthic drug where we use this anti-helminthic for other purpose. So it is the anti-helminthic mainly. We use in strongyloidosis, we use in the onchocerciasis. Anti-helminthic it is good, used in the nematodes. But if you see, out of these, where it is that drug used, it can be used for ascaris but not a choice. Albendazole is used, so it is not a drug, good drug for this purpose. For cholera, there is no role. For fungal infection, no. It is the drug we use for scabies, Sarcoptes scabies. In the scabies, we use single dose. We use the single dose. Single dose 12 milligram for adult patient. If required, you can repeat after 1 week. It is only used when the permethrin is not effective. Otherwise, permethrin topical is the drug of choice. Permethrin topical is the drug of choice. Permethrin 5% topical application. So we use the permethrin as a drug of choice. But if needed is severe scabies or resistant scabies, then you can add the oral drug. So ivermectin is the oral drug. So used for scabies and lice, pediculosis. Next question. Again recall based question related to adverse reaction. Gynecomastia is caused by which ATT drug? Gynecomastia caused by which ATT drug? This question I think everybody knows, but frequently asked, that's why we have mentioned. So remember the drugs, Disco. These drugs are commonly causing gynecomastia. D for digoxin, I for isoniazid, S for spironolactone, C for cimetidine, K for ketoconazole, O for estrogen or omeprazole. These drugs are commonly causing gynecomastia. These are anti-androgen. So out of the ATT, it is the isoniazid. Out of the ATT, it is the isoniazid. But this is not the common side effect. The common side effect of isoniazid is niazid neurological, rifampicin R red orange discoloration of secretions like urine, sweat, pyrazinamide Z for joint pain, arthralgia, hyperuricemia, and ethambutol E for eyes, ocular, optic neuritis. Now comes to next question. Treatment of tuberculoid leprosy. Treatment of tuberculoid leprosy. So we have the multibacillary, paucibacillary. In the past, the treatment was different. But now you will see the treatment is same. So can you tell me what is the correct answer? You have to be updated in pharmacology. If you will see the old thing, then you will get confused and you will get the wrong answer. So nowadays, for all the leprosy patient, whether multibacillary or paucibacillary, the same drug, the only duration is different. So in all these, we use the rifampicin, dapsone and clofazimine, RDC regimen. Remember, rifampicin given monthly, 600 mg monthly dose. Remember, dapsone is given daily, dapsone 100 mg daily. And remember, clofazimine given monthly as well as daily. It means all these three drugs are used. Dapsone daily, rifampicin monthly, clofazimine monthly as well as daily. 300 mg monthly and 50 mg daily clofazimine, that is having anti-inflammatory property as well. The only difference is duration. In multibacillary, we use for 12 months. In paucibacillary, we use for 6 months. That is the only difference. So what is the correct answer? Option C. Nowadays, we don't use the ROM regimen. In the past, we used to give the ROM regimen for single patch, single lesion. But now we don't. So that is the C correct answer. Very good, guys. Next question. Voriconazole. Voriconazole not effective for. Voriconazole not effective against. So voriconazole is one of the antifungal drug. In which patient it is not effective? In which infection? Candida albicans, mucormycosis, Candida tropicalis or aspergillosis, where it is not effective. So remember, voriconazole is one of the important azole, and azoles are very good spectrum. For Candida, they are wonderful. For aspergillosis, wonderful. It is the drug of choice in aspergillosis. But remember, voriconazole, itraconazole, fluconazole, they are not effective for mucormycosis. For mucormycosis, the azoles which are effective are posaconazole and isavuconazole. Posaconazole and isavuconazole. But they are not the drug of choice. The drug of choice for mucormycosis is liposomal amphotericin B. Liposomal amphotericin B. So, answer will be mucormycosis. So, in mucormycosis, the drug of choice is LAMB. Don't forget, liposomal amphotericin B. Voriconazole is not effective. Posaconazole, isavuconazole, they can be used. Out of azoles, only these two. But they are not the choice of drug. So you can see in antibiotics where they are not effective, that is also important, because injudicious use, irrational use of antibiotic may leads to resistance. So we should know the correct use and we should know the correct dose and correct duration, because if not completing the course, that is also leads to resistance ultimately, injudicious use. So rationality is very important in the antibiotics. The next is the drug used to treat acyclovir resistant herpes in the simplex as well as varicella zoster. So usually the drug of choice for herpes except cytomegalovirus, in all we use the acyclovir. But acyclovir need to be activated because it's a prodrug. It need to be activated by the enzyme. If this enzyme is not there, if this resistance or mutation in this enzyme, what happens? The virus will be resistant to acyclovir. Acyclovir not be effective. So the drug which is not depending on the enzyme can be used for these patients. So which drug out of these not activated by the enzyme? What is the correct answer? Because acyclovir triphosphate formation is must. If there will be no triphosphate formation, it will not be effective. So what is the correct answer? So I can see you are giving the answer as B, but that is not correct, because valacyclovir is nothing different. Valacyclovir is the prodrug of acyclovir. It is acyclovir only, ester prodrug with better bioavailability. But that is not the drug for this purpose. Okay, you have given the answer D. So that is again not correct. Ganciclovir is the drug for cytomegalovirus. It is not for resistant herpes. So you have to find something which is not going to activated via the enzyme, directly effect. So what is the correct answer? Out of these, foscarnate. Foscarnate is the drug of choice for resistant herpes, resistant cytomegalovirus. In the resistant infection, out of the herpes infection, cytomegalovirus infection, foscarnate is the drug of choice. Abacavir definitely not for this purpose. Abacavir is the drug for hepatitis B. So foscarnate is the drug. So yes, Manoj has given the correct answer. So you can see that now the level of question is increasing. So you should know every type of question. It's not like only tough question. It's not like only easy question. It's not like you have to know everything. Simple concept, drug of choice which is not useful, how they are useful, then how to apply them clinically. Now this question have been asked in the NEET PG exam, FMGE exam, INI-CET, antiviral, you know the HIV, antiretroviral therapy. So which antiviral drug having dual antiviral activity against HIV as well as hepatitis B? And it is effective for both. It is most effective drug for both. Which drug is this? If you see the option enfuvirtide, tenofovir, abacavir or entecavir, which antibiotic is this? Antiviral is this? So enfuvirtide, it is the fusion inhibitor, fuvirtide. That is only for HIV. That is only for HIV, not for hepatitis B. That is the fusion inhibitor. Abacavir, that is also for HIV only. That is also for HIV only. Entecavir, that is for hepatitis B only. Hepatitis B. So now you got one drug. That is the correct answer. Tenofovir is the drug which is nucleotide analog. It is the nucleotide analog. It is effective for HIV as well as hepatitis B both, and it is the most effective drug for HIV as well as hepatitis B. Tenofovir, nucleotide reverse transcriptase inhibitor. Nucleotide reverse transcriptase inhibitor. So that is for both. Except kidney patient, it is used in all HIV patient, but in the renal failure patient it is not safe. Can you tell me the alternate of tenofovir in kidney patient? Because it is not safe for renal failure patient. So can you tell me the alternative of tenofovir in the renal patient? In the options only we have the drug. So the drug for renal failure for antiretroviral purpose we use the abacavir. Option C, abacavir. So tenofovir is the most effective drug. That's why we use the TLD regimen now. If you see the regimen for HIV, we use the TLD regimen. Tenofovir, lamivudine and dolutegravir. Tenofovir, lamivudine and dolutegravir. We use that. Okay. Very good, guys. Sofosbuvir, no, sofosbuvir for hepatitis C. Sofosbuvir for hepatitis C, not for this. Yes. So cobicistat, important drug, cobicistat. See the name, C-stat. It's a CYP inhibitor. Cobicistat is the CYP inhibitor. It is not antiviral drug. It is used with which drug? As a booster. So it is basically CYP inhibitor is a booster therapy. It's a booster therapy. So against with which drug it is used to boost the effect. So one specific combination is available with cobicistat. If you know, that is recall based, but it is important anti-HIV. So guys, it is available with Elvitegravir. So we have Elvitegravir with cobicistat. We have the Elvitegravir with cobicistat. This combination is available as a booster therapy. Atazanavir, darunavir, these are protease inhibitor. Protease inhibitors, if combined, they have their own booster. Ritonavir, lopinavir combination, that is a booster. But cobicistat is CYP inhibitor, especially approved with integrase inhibitor. Elvitegravir is the integrase enzyme inhibitor. That is the direct question. Next question from the adverse effect. All of the following are side effect of metronidazole except metronidazole is commonly used drug for anaerobic infection, wonderful for anti-protozoal like in the amoebiasis. It is having antibacterial, B vaginosis, anaerobic infection, and it is important drug for amoebiasis. It is the drug of choice. Giardia, amoeba, trichomonas. Common side effects. The most common side effect is metallic taste. That is the common. The question is about the except. That is seen. Metallic taste, that is the most common. Why you are saying B? That means you are not reading the question properly. Disulfiram reaction seen, that's what is not given in alcoholic. Seizures risk is there, but that is not common. Seizures risk is there, but that is not common. Tendonitis, that is seen with the fluoroquinolones. Tendonitis seen with the fluoroquinolones. Ciprofloxacin, levofloxacin, these drugs are causing the tendonitis. Yes. So tendonitis is not seen with these metronidazole. Rest of the all side effects are seen with the metronidazole. And out of these, metallic test is the most common. And in alcoholic patient, disulfiram like reactions. So very simple but very tricky question, very important question. Okay. And you can see the topics I have selected, they all are very important topic. Anti-HIV, antiviral, then some of the important antibiotics, some antifungal. Now let's see. The HIV drug entry inhibitor Maraviroc acts at the. So we have the target of inhibiting the entry. So the virus enter the CD4 cells. The drug which target the virus envelope was enfuvirtide, but the drug which target the CD4 cells. So it is the drug which is inhibiting the entry. Yes. So all of you have given the correct answer. This is the CCR5 antagonist. Very good, guys. It is the CCR5 antagonist. So Maraviroc. See, Mara, Vir, virus on CD4 cells. So CCR5. We have one monoclonal antibody nowadays, you know. Ibalizumab. Ibalizumab is the non-specific for CD4 cells. It is the monoclonal antibody approved for HIV. So it is the post-attachment inhibitor. Ibalizumab. Remember the Bali. Bali gives HIV. Just to remember. Next question. Drug of choice in patient with severe complicated falciparum malaria in the first trimester of pregnancy is. The drug of choice for severe complicated malaria in first trimester of pregnancy. Tell me, guys, what is the answer? Let me tell you, mefloquine is not the answer because mefloquine is not the fast acting drug. Let me tell you, chloroquine is not the answer, because chloroquine is not for falciparum, because it already resistance is there in the falciparum. So now either the answer will be B or the answer will be C. So you have to see the pregnancy and you have to see the first trimester of pregnancy, because artesunates can be used during pregnancy. In second and third trimester they can be given. In first trimester we should avoid. What is the best drug for complicated malaria in the first trimester? That is quinine. In the first trimester it is the quinine, but if second or third trimester it is the artesunate. And remember guys, overall drug of choice is definitely artesunate. The overdose of quinine is called as synchronism. There is risk of hypoglycemia, tinnitus, vertigo, black water fever seen with the quinine. So that's why overall drug of choice is artesunate. See the next question from the helminth infestation. DEC, diethyl carbazine, is used for the treatment of all except where we don't use the DEC. Options are filariasis, loiasis, bilharziasis, or tropical pulmonary eosinophilia. DEC, important drug. It is the drug of choice for filaria. The question is except, Alokji. So in filariasis it is used. It is the drug of choice. In loa we use it. Why we don't prefer ivermectin in the loa? Because there is risk of encephalitis by the ivermectin. If you give the ivermectin, there will be reaction and it can cause the inflammatory reactions in the brain. So there will be encephalitis. That's why we use the DEC. Tropical pulmonary eosinophilia, that is seen in the helminth infestation. So in that also we use DEC. We use the steroids. We also give the anti-helminthic drug. Bilharzia. What is bilharzia? Bilharziasis. So in that we use the praziquantel. Bilharziasis. Fluke. In flukes we give the praziquantel. It is the drug for bilharziasis is praziquantel, not the DEC. So DEC used in filaria, loa. In pulmonary eosinophilia we add. Whenever you will see the patient, if there is allergic symptoms, allergic cough and all, you advise for eosinophil count. If it is high, we give the anti-helminthic drug. Bilharziasis, praziquantel. In the flukes, in the trematodes, flukes or cestodes, we prefer the praziquantel. Remember the majority reaction by the DEC, majority reactions. So that's why in filaria, loa, whenever we use, be ready for the majority reactions. Majority reactions in with the ivermectin and DEC, these two drugs. Next question is dhamakedar. True except regarding drug associated with the ototoxicity. Drug associated ototoxicity. What is true except? Options are: tinnitus is the earliest sign of aspirin toxicity. Amikacin cause reversible deafness. Ethacrinic acid causes reversible hearing loss, and cisplatin causing irreversible hearing loss. बताओ जी. Okay, Dr. Nikunj is saying कि sir option C. Any other answer? So let's see one by one. Tinnitus is the earliest sign of aspirin toxicity. That is absolutely true. Tinnitus, ringing sensation in the ear, that is the sign of aspirin toxicity, salicylism. Then amikacin cause reversible deafness, aminoglycosides. Aminoglycosides, amikacin. Amikacin is one of the aminoglycoside. Amikacin, kanamycin. They do not cause reversible. They cause the irreversible hearing loss. Ethacrynic acid is one of the loop diuretics. And loop diuretics are mainly causing reversible hearing loss. It is very rare they cause the irreversible hearing loss. They are mainly causing the reversible hearing loss. Cisplatin, that is causing the irreversible hearing loss. So what is false? The false is option B, aminoglycosides, antibiotics. We are discussing or taking the class of antibiotic. So think about the antibiotic. Out of these, only one antibiotic, amikacin. The answer is that only. If you think illogically. So amikacin cause that's why these three drugs, loop diuretics, amikacin, cisplatin or aspirin, they should not be combined together because of high risk of toxicity. So the correct answer will be option B. Now let's see the next question. This is again practical question, but it have been asked in the exam. Double strength cotrimoxazole is. It is available with the name of Septran. We have the single strength Septran, we have the double strength Septran. Septran SS, Septran DS. It is the DS. So definitely DS means double dose. So it is not the option A or B. Now think about the C or D. That is the double dose. So the ratio in the cotrimoxazole, combination of sulfa and trimethoprim, the ratio is 5:1 or 1:5. So which is 5, which is 1? Which is 5, which is 1? Tell me. Is sulfa 5 or trimethoprim 5? Because the ratio in tablet is 5:1. So you can see 160-800 sulfa tri or 160-800 tri sulfa. What do you think, guys? 1:5 or 5:1? You have to see. So always remember, sulfa S is like 5. Sulfa S is 5. Trimethoprim tri is 1. T is like 1. S is like 5. That is the 5:1. So which is 5 sulfa and which is 1 tri. This is the ratio. In plasma this ratio is 20:1. In the tablet it is 5:1. So sulfa 5 and tri is 1. So what is the correct answer? You can see. It is the option D, not the option C. Okay. Let's see the next question. Important question from the antifungal. In antifungal, you know the mechanism of action. In antifungal, mechanism of action is very important. Selection of antifungal and mechanism. So let's see the mechanism. Following are the correct combination of drug and its mechanism except. So they're asking the false. So let's see one by one. Polyenes, PO. This PO create the pores. Polyenes like nystatin, amphotericin. The polyenes causing the pores. Binds to and disrupt the cell membrane. That is true because they create the pores. Okay, let's see the option B. Dr. Satyendra, let's see. Griseofulvin block intracellular microtubules. Yes, they are microtubule inhibitor, M phase inhibitor. So that is true. That is true. Griseofulvin is one of the M phase inhibitor. Microtubules like colchicine. Allylamine. Allylamine is one of the terbinafine drug, allylamine group. They are inhibiting the ergosterol synthesis by inhibiting the squalene epoxidase. That is true. Used for dermatophytosis, nails infection. Then flucytosine. inhibit cytochrome P450 dependent 14 alpha demethylase. Is this true? 14 alpha demethylase. Which drug is this? This is fluconazole. This is seen with the azoles, not the flucytosine. Flucytosine, see the name, cytosine. So that is the metabolite, metabolic inhibitor. Cytosine is the purine analog. Sorry, this pyrimidine analog. The flucytosine, pyrimidine analog. The remaining pyrimidine analogs we use in the cancer. The flucytosine is the pyrimidine analog used in the with the amphotericin B for cryptococcal meningitis. So this mechanism is for azoles, not the flucytosine. The correct answer is option D. So don't forget the mechanism of antifungal. Let's see. Now you will get the clinical question. A few clinical questions now. This drug has activity against many strains of Pseudomonas aeruginosa. However, when it is used alone, the resistance has emerged during the course of treatment. Its activity against gram-negative rods is enhanced if it is given with tazobactam. Which drug is this? This drug is very effective against gram-negative rods Pseudomonas, but now resistance. Yes, very good, Dr. Saab. So, given in combination. So, see the option amoxicillin, aminopenicillin. Aminopenicillin not effective for Pseudomonas. Aztreonam effective for Pseudomonas, but no need to combine with the tazobactam. Imipenem not to be combined with the tazobactam. Which is combined with the tazobactam? This is the piperacillin. Pipratazo. Piperacillin plus tazobactam. Piperacillin is one of the penicillin which is effective against Pseudomonas, or you will say it is the most effective penicillin against Pseudomonas. Resistance issue, beta-lactamase enzyme. So we have the combinations now. Piperacillin plus tazobactam is available. Beta-lactamase inhibitor. So what is the correct answer? It is the piperacillin. Let's see the next question. It is again important clinical question. You are called to evaluate a 30-year-old male patient in the hospital who has been admitted for endocarditis. He is complaining a red flashing over his entire body. The patient blood culture had grown out methicillin resistant Staph aureus MRSA, and the intern had recently started him on antibiotic therapy. Which antibiotic is responsible for this? सारी गलती इंटर्न से करा लो, बेचारे इंटर्न को फंसा रहे हैं, जबकि everybody knows, even the MBBS student knows about it. Why the intern will do this mistake? If you give the rapid injection of the drug, there will be problem. So give it slowly. If you will give it slow, there will be no problem. If it occur, you stop the drug and immediately and give the antihistaminic. So what is the diagnosis? This is a typical case of Redman syndrome due to histamine. Typical case of Redman syndrome due to histamine. So which drug out of these cause the Redman syndrome? It is the vancomycin. What is the effect of chloramphenicol? Chloramphenicol causing the grey baby syndrome. Chloramphenicol causing the grey baby syndrome. Vancomycin causing the Redman syndrome. Very important question. Vancomycin, Redman syndrome, give it slow. Okay. So the correct answer will be vancomycin. Next question. A 30-year-old woman present to your clinic complaining of rash. She report that she was gardening out the day before and woke up this morning with lesions on the back of her neck and forearm, sun exposed area. On physical examination, the patient has maculopapular lesions over the sun exposed area. The rash is most likely due to which antibiotic? Again, important question. So whenever you give this antibiotic, advise the patient to use the proper sunscreen, use the umbrella, or avoid the sun exposure, because there is risk of photo-allergy. Which antibiotic out of these causing photo-allergy? Options are azithromycin, metro, or ceftriaxone. Which antibiotic? No. Ceftriaxone is not causing the photo-allergy. Azithro not causing the photo-allergy. So that is the doxycycline. Yes. Option B, doxy. That's why in African country doxy is less commonly used. So doxycycline having risk of photo-allergy. So the correct answer is doxycycline. Very good, guys. See one more question. Clinical question. A 20-year-old woman with recurrent sinusitis has been treated with different antibiotics on several occasions. Typical Indian. During the course of such treatment, she developed a severe diarrhea and was hospitalized. Sigmoidoscopy reveals colitis and pseudomembranous colitis were confirmed histologically. Which of the following drug administered orally is most likely to be effective in this diarrhea? Orally administered, most likely to be effective. Which drug is this? Nowadays the most effective drug is fidaxomicin, but that is not in the choice. We use the fidaxomicin, we use the vancomycin, we use the metronidazole. These drugs we use. And nowadays we have one monoclonal antibody also, baslitoxumab. That is the monoclonal antibody. So what is the correct answer? So for this patient, yes, very good. So we use the vancomycin. So clindamycin is having high risk. Clindamycin is having the high risk. It is causing this problem. Ampicillin can cause this problem. So we use vanco or metro, but the most effective drug out of these is vanco. But overall the most effective drug is fidaxomicin. Very good, guys. So the correct answer will be vancomycin, pseudomembranous colitis. Okay. So now this question. 32-year-old male physician from Paris is planning to participate in a medical conference in India. Very typical scenario. उल्टा हो गया ये तो. In addition to a hepatitis vaccine, he wished to take prophylactic medication for other serious illness that he may encounter during the visit to India. You advised him a medication that will serve as chemoprophylaxis for malaria. It should start 1 week before and it should be continued for. First tell me which drug is this. So if chloroquine sensitive area, then chloroquine. If chloroquine resistant area, then we use the mefloquine. But if the journey is short, unplanned, then doxy. In less than 6 week journey, we give the doxy. If more than 6 week journey, we give the mefloquine. So when we use the chloroquine or mefloquine, we have the time to start at least 1 week before, 1 to 2 weeks before. But when it should be continued for how many weeks? Very important question. So it should be given for 4 weeks after returning back. So give every week 4 weeks after return. Continue up to 4 weeks. For short duration, we can use the doxy. And doxy is fast acting drug. You can start 1 to 2 days before daily dose. So the correct answer will be option D. Okay, so the last question regarding the recently introduced lipid formulation of Amphotericin B, LAMB, which is accurate statement. Options are: they are less expensive to use than the conventional Amphotericin B. Is this true? They are more expensive. LAMB is more expensive. So is this true? No, this is false. They are less effective in fungal infection because they increase tissue uptake of Amphotericin B. So they are not less effective. False. They are very effective. Then they are having decreased nephrotoxicity of Amphotericin B. Yes, that is the purpose. The targeted drug delivery. Targeted drug delivery. So because of targeted drug delivery, you will get the less toxic effect. They have the wider spectrum. No, the spectrum will be same. The spectrum has not been changed. The drug is same. So the correct answer will be option C. The option C is the correct answer. Option C. So guys, that's all about this class. We covered almost every drug. You want to know the detail of all these topics? Watch my videos in second year course. Separately for second year, we have recorded all the videos based on the latest CBME curriculum. So that's all. Keep studying, keep revising. Wish you all good luck for your study, for your future. Thank you. If you guys are having any doubt, you can touch me on my Instagram. This is my Instagram handle, dr_Dinesh Yadav. So see you all. Thank you. In next video, we'll discuss anti-cancer. So we have discussed all the topic wise video. In the next, we'll discuss the anti-cancer. That will be the last video for second year course. So thank you. Bye bye. Take care. Good night.